Assalamualaikum and good morning to one and all. Today we'll study about part 2 of drug used in a special population. So we'll study about pediatric patient in today's session. I am Professor Sheikh Abu Sufyan. Welcome you to my YouTube channel Pharma Learning Forever. At the end of this e-learning session, you are able to explain challenges in giving medicine to the pediatric patient and discuss pharmacokinetic and pharmacodynamic changes in pediatric patient. So today's session will be focused on the pediatric patients. Those are children and those are small child. So let's start with the challenges of the pediatric patient. So when we are giving medicine to the pediatric patient, we must consider many factors. So most of the time, as a pharmacist or as a physician, we feel that since pediatric patient it is the smaller version of the human being, so what we can do, we can reduce just dose of the drug. And there are many formulas you might have studied in the pharmacology 1 where you have seen that the dose of the drug, it is decided on the basis of the body weight. But that is not a true or good practice in case of all type of the medicines. So let's see why that is not a good practice. The reason is that children cannot be considered as a miniature adult. So you cannot consider the children as a miniature of the adult due to two important reasons. First reason is there is difference in the body constituent. So in case of the child, their body constitution it is completely different, and due to the difference in the body constitution, there is change in pharmacokinetic parameters such as absorption, distribution, metabolism and excretion of the drug. And if these pharmacokinetic parameters are changed, then it is going to produce the adverse effect or the bad effect in the pediatric patient. So this is one of the parameters. There is difference in the body constitution with reference to the absorption, distribution, metabolism and excretion. In addition to that, there is also difference in the sensitivity to adverse drug reaction. We'll see it in case of few drugs where in case of adult patient, the drug it acts as a CNS stimulant. Whereas in case of pediatric patient, the same drug it produces the reverse effect. Likewise, the phenobarbital, it is the hypnotic drug which is supposed to produce the sleep in a patient. In pediatric patient, it produces the hyperkinesia. So this is the difference effect. Okay, so this is due to the difference in the body constitution and the reactivity of the pediatric patient to the drug. You cannot consider pediatric patient as a miniature of the adult. So just reducing dose it is not sufficient. So depend upon the medicine, depending upon what disease for which you are giving the treatment given to the pediatric patient, it needs to be changed. Okay, so this is one of the challenge while giving medicine to the pediatric patient. Another challenge, it is with reference to the research that we conduct in case of the pediatric patient. So when we do the research in case of clinical trial, so in clinical trial, whenever you conduct a research, you need to take the informed consent. Without taking informed consent, you cannot conduct the research. And unless and until you are not trying drug on the patient or the human being, that drug cannot be marketed for the treatment of that particular class of the patient. For example, most of the time in clinical trial, you do the study on either human volunteers or you are doing the study on the patients. Okay, so those are adult in nature. Generally, you doesn't prefer taking the child or involving child in a clinical trial. That is not ethically allowed because informed consent is difficult because pediatric patient is not one who can take their own decision, isn't it? They cannot take their own decision. Obviously, their parents should take the decision, and that is not ethically allowed for the clinical trial. So the informed consent is the problematic, and commercial interest it is also less. Since commercial interest is less, many manufacturers or many pharmaceutical industry, they doesn't take more interest in developing new molecules for the treatment of the pediatric patient. So due to these two important challenges, of the informed consent and commercial interest, that is less in case of pediatric patient, the clinical trial in the children have lagged behind those in the adult. So if you see the clinical trials, or if you see the data of last 10 years about the clinical trial, you will come to know that most of these trials are conducted for the adult patient, or for giving treatment to the adult patient. There are very less drugs which are only focused on either pediatric patient or to the elderly patient due to this limitation. So these are two important challenges. Due to that, giving pharmacotherapy to the pediatric patient, it is very challenging, and it should not be done by the general physician. Rather, the treatment to the pediatric patient should be given by someone who is specialist in the pediatric department. So you must take treatment from the pediatrician, because pediatrician having these all knowledge about the different aspect of the pediatric treatment, and he is one who can decide how right treatment can be given to that particular child. Okay, so we have seen about the challenges for giving pharmacotherapy or the medicine to the pediatric patient. Now let's see what are the different types of differences which are seen in pediatric patient. So even in case of geriatric patient, those are elderly in nature, we have seen that there are two important differences that matters and that going to affect the pharmacotherapy. So first difference, it is a pharmacokinetic difference. So obviously in pharmacokinetics, there are four important parameters that we are going to study, which are called as the ADME, that is absorption or distribution, then metabolism and excretion of the drug. So this is also change in pediatric patient. Likewise, you may also see the pharmacodynamic difference in pediatric patient. So step by step we'll see all these parameters, how it is changed in case of pediatric patient. So let's start with the pharmacokinetic difference. So in the pharmacokinetic, we'll first see about the absorption. So in case of absorption in pediatric patient, it is observed that the GI absorption, it is slower, and we know that the important route of drug administration, it is the oral route. And if you want to give the treatment by any other route like the intramuscular injection or IV injection, that is not much convenient in case of the child. The reason is that for such route of administration, you need physician to come to your house, or maybe you need to take your child to the hospital to give this treatment, isn't it? So GI absorption, it matters, because most of the time we are giving medicine to the child through oral route. So what is the problem with GI absorption? The GI absorption, it is the slower. Since GIT absorption, it is slower, obviously proportionately it also delay the pharmacological action of that particular medicine. So this is the problem with the GI absorption in case of pediatric child. Let's see with another route of administration. For example, in case of intramuscular route, that is much convenient as compared to intravenous route, because intravenous route you need to identify the vein. In case of the child, that is again challenging, and it is the painful to the child. So in case of intramuscular injection, if you give the medicine through intramuscular injection, the absorption through this route, it is too fast. Okay, so with the GIT, the absorption, it is too slow, whereas in case of intramuscular route, absorption, it is too fast. But when you are giving medicine to any patient, you need to have the appropriate route of administration, which ensure the constant plasma concentration, it is attained in the body. So the drug concentration in the plasma, it matters, and that must be the adequate to produce pharmacological action. So if you want that type of situation, then the solution could be to ensure adequate blood concentration, reach systemic circulation. It is the only one route, that is intravenous route. Okay, so what you can do in those drugs where generally therapeutic index, it is narrow, where slight increase in concentration may produces the toxicity, or slight decrease in a concentration, it produces the under effect. So there is no pharmacological effect. So in such case, there is a narrow therapeutic index. So those drugs which having narrow therapeutic index and need to be monitored through therapeutic drug monitoring, those drugs must be given through IV route. So when you give drug through the IV route, you can able to ensure adequate blood concentration that is reaching systemic circulation. Now once concentration it is coming in between therapeutic range, it is going to produce good pharmacological effect. Suppose if doesn't reach, suppose if you are given through the oral route, then this could be the condition. It is not coming in therapeutic range. It is coming below therapeutic range, isn't it? Or maybe you have given through intramuscular route, maybe it is unpredictable and sometimes it is going above therapeutic range, and the concentration of the drug, if it's go above therapeutic range, it may produce the toxicity. So in case of drug with narrow therapeutic index, in case of the child, the preferred route it is IV route of administration. Okay, so this is about the absorption of the drug. Next parameter it is with reference to the skin absorption, and it is quite logical that in case of pediatric patient or the child, the skin is very thin, and since the skin is very thin is there, and when you apply any drug on the skin, then it is observed that that drug undergo the process of percutaneous absorption. So the absorption through the skin, it is called as percutaneous absorption. So any drug application, especially which is lipid soluble in nature, if you apply that drug on the skin, it may undergo the process of percutaneous absorption through the skin. So you must take the precaution when you are giving some drug. You see that it doesn't touch to the skin of that patient, otherwise it may absorb into the blood circulation and it may causes systemic toxicity. And it was observed with many topical corticosteroid. So in case of topical corticosteroid, if you have used it, maybe sometime you are using to reduce the pain and the inflammation. So in such case, if you are using it to the pediatric patient, then you see that you are giving the less dose of this drug, because in case of the adult, since skin it is a thick, in that case the percutaneous absorption it is low, so you need to give the more dose of topical corticosteroid. But in case of the child, you need to accordingly reduce the dose, because it may have produced very severe percutaneous preparation. So when you give the drug through oral liquid preparation, so generally you are not giving tablet, or you are not preferring giving capsule to the child. Why? Because it is difficult to swallow and they doesn't love to take, and they have resistance to it, sometimes due to the bitter taste. So what you are doing, you are giving medicine through the oral liquid preparation, which are flavored and sweet in nature. But issue with oral liquid preparation is that, suppose if you have used a suspension and if you have not shake the bottle, then in such case uniformity of the dose may not go to the patient. And if there is no uniformity in the dose given to the such pediatric patient, it is less accurate, right? So this could be one of the possibility if you are using the suspension formulation. And in case if you are using the solution which is thick in nature, then sometime maybe if you have used even the bottle cap itself to give the drug or to give that liquid preparation to the child, then most of the time, suppose if you have given the 5 ml, then it is observed that the 1 ml or 2 ml of the residual drug, it remains in that cap only, right? So overall result is there is a less accurate dosing. It is happen in case of the liquid preparation. So these are different problems are there in case of the pediatric patient with reference to different route of administration. Let's move on to the next part of today's session. So we have seen about the absorption of the drug. Now let's see how distribution it is affected in case of pediatric patient. So in pediatric patient, the body fat content, it is relatively low in the children. So it is exactly reverse of what we have studied in last lecture. So in case of elderly, we have studied in last lecture. So in elderly body fat, that there is a lower volume of distribution, especially in case of the fat soluble drug. Whereas in case of elderly patient, we have seen that the elderly patient having the more volume of distribution for fat soluble drug, right? So here there is lower volume of distribution for the fat soluble drug. So accordingly, depending upon the relative ratio of the fat to water, the distribution of the drug in pediatric patient is affected. So when you are giving the lipid soluble drug, you must be cautious. You need to accordingly adjust the dose because it lead to a low their volume of the distribution. So example like diazepam and many drugs are there which are fat soluble in nature or having more or they can easily crosses the fatty membrane into the body, right? So when you are giving such drug, you need to take the extra precaution and you need to also adjust the dose of the drug. Okay, so this is the one parameter in the distribution. So point to be remember here is there is a lower volume of the distribution for fat soluble drug, whereas in case of the plasma protein, it is observed that the plasma protein like the albumin, their level it is reduced in the neonates, and we know that many drugs they bind to the plasma protein. Now if the level of plasma protein like albumin if it is reduced, then obviously the free concentration of those drugs which supposed to bind to the albumin will increase. Now when these drugs become free from plasma protein, what these drugs are doing in case of the children, they are replacing the bilirubin from the binding site. So now when bilirubin it was not actually present in the free form, or if it is present but to up to certain extent, but now since the plasma protein albumin level it is reduced in case of neonates, so if you give drug like sulfonamide which is supposed to bind to the albumin, now since the albumin level it is less, so now their concentration become free, and what they will be doing, they will displace bilirubin from binding site, and when bilirubin it is displaced, now bilirubin will come into blood circulation, and that is the reason we have seen that many a time in case of the children they suffer from the jaundice. Most of the time the newborn baby they are suffer from the jaundice if you give any medicine which having the high plasma protein binding, and this condition it is called as the kernicterus. So the kernicterus it is the condition where the drug like sulfonamide is supposed to bind to the albumin. Since albumin level it is less, what they are doing, the free concentration of the sulfonamide will displace the bilirubin from the binding site, and due to displacements of the bilirubin, the plasma concentration of bilirubin will increase. Okay, so and if the plasma concentration of bilirubin if it is increased, it is yellow in color, the baby skin become yellow, and you call it as the jaundice. The baby might be suffering from the jaundice. Okay, so this condition is called as the kernicterus. So reason is the reduced in plasma protein, that is albumin. So this could be the issue due to the reduced plasma protein in case of the child. Likewise, as far as the blood-brain barrier is concerned, it is observed that in case of the child, blood-brain barrier it is more permeable. The reason is that the child blood-brain barrier it takes some time to develop. Since it is not completely developed, it is highly permeable to the drug. So any drug which is lipid soluble can goes to the brain and it may produce adverse drug reaction. So you have to be very cautious when you are giving any medicines to the child which is lipidic in nature, because it may cross the blood-brain barrier, it may reach to the brain, and it increases the risk of CNS adverse effect. So to avoid CNS adverse effect, you need to adjust the dose of those drugs which are highly lipidic in nature. Otherwise, they will go to the brain and they may produce the adverse effect. So this is the problem with the distribution of the drug. Now let's see what happened about the metabolism of the drug in the children. So the metabolism of the drug is very unpredictable and it's quickly changed as the age is advanced. Okay, so like at a birth, hepatic enzyme system it is relatively immature because liver is not completely developed. Since at a birth the hepatic system or hepatic enzyme system it is not mature, it is immature, particularly in case of the infant. So if you are giving the drug which is supposed to be metabolized by the liver will not metabolize, and we know that if drug is not metabolizing, it will also not excrete into the urine, right? And it slowly increases their concentration in the body and it may produces the toxic effect. So such effect it is observed with the well-known antibiotic, that is chloramphenicol, and we have seen several times that chloramphenicol should not be given to the newborn baby. Why? Because it produces the gray baby syndrome in the neonates, and this gray baby syndrome it happens because there is no proper development of hepatic enzyme system which metabolize the chloramphenicol, and due to that the level of chloramphenicol it is increased to the toxic level, and one of the symptom of the toxicity of the chloramphenicol in newborn baby it is gray baby syndrome. So that is not advisable. So that is the reason generally what we are doing, we prevent or we avoid giving the medicine which is supposed to be metabolized by the hepatic enzyme system in case of newborn baby. So this is the problem with the metabolism. So or the overall, to summarize, the metabolism it is generally decreased in case of the newborn baby. Now I am talking about the newborn baby. Now let's move on to what happens when age is progressed. Like when the baby becomes just 4 week old. So newborn baby it means first 1 to 2 week old, and if the baby if become a first 4 weeks old, so after first 4 weeks it is observed that there is a reverse effect. Why this is a reverse effect? Because the liver it's quickly mature. So due to the quick maturity of the liver or the rapid maturity of the liver, the process become reverse. So now let's see why it is happening. Because the ratio of weight of liver to the body weight it is up to 50% higher than adult if the age of baby it is 4 week old. Okay, so now you see there is no much difference between the 4 week and newborn baby. It is just 1 month old baby. So after 1 month of the age of the baby, now the liver function it is exactly reverse. Where we have seen in case of newborn baby, the liver was not mature, but after 1 month you can see the liver it is quite mature, and rather it is much more mature as compared to adult, because as compared to the body weight the ratio it is 50% higher as compared to adult. It is the sedative and hypnotic drug, and it belongs to the category of the barbiturate. So what phenobarbital does, when you are giving phenobarbital to the patient, it reduces their effect because it undergo very quick metabolism, and if drug it is quickly metabolized, obviously it is going to reduce their pharmacological action. Okay, the depend upon the age of the child, you can see there is quick change in the pharmacological action of the drug. Like let's see what is the effect in case of the excretion. In case of the excretion, it is observed that all renal mechanism like the filtration through the kidney, then the tubular secretion and tubular reabsorption, it is reduced in the neonates. So the overall effect it is the less the renal excretion of the drug. So the renal excretion it is relatively reduced in the infant. And how it is going to affect pharmacological action of the drug? So if the drug it is not excreted into the body, the drug will start slowly accumulating into the body, and there is slow accumulation of the drug, and this slow accumulation of the drug due to reduced in the renal excretion, because kidney is not completely developed, it is not mature enough to have the normal filtration, secretion and reabsorption of the drug. And since it is not happening, the drug is not excreted, it start accumulating into the body. So usual dose if you are giving in case of the child, it is quite possible that it may produce the toxic effect in case of the children. So this is how the excretion it is changed, and due to change in excretion or the pharmacological action of the drug, it is also effect in case of the pediatric patient or in case of the neonate. So we have seen all 4 parameters, that is absorption, distribution, metabolism and excretion, all are changed. So to summarize, the absorption is depend upon the route of absorption, route of drug administration. The best route to achieve the desired concentration or expected concentration, it is the IV route. We have seen in case of the distribution of the fat soluble drug it is decreased due to decrease in the ratio of the fat to the water. Plasma albumin level it is decreased, and we have seen due to that the sulfonamide it produces displacement of the bilirubin, and it produces kernicterus as a disease. Okay, then we have seen about the metabolism of the drug. So liver function it's completely depend on the age. In case of neonates it is completely immature, but after 4 weeks of the age of the baby it is much more mature even as compared to the adult. Okay, and due to that we have seen in case of the newborn baby there is slow metabolism, whereas after 4 weeks of the age of the baby it produces the quick metabolism. And in case of phenobarbital, just now we have seen it produces the fast metabolism and it reduces their pharmacological action. Then in case of excretion we have seen it is reduced, all functions are reduced because it is not completely mature, and due to that it increases the possibility of accumulation related toxicity in the body, right? So these are all pharmacokinetic changes which are seen in case of pediatric patient. Let's see what are the pharmacodynamic changes which are seen in case of pediatric patient. So the data, it show that there are documented evidences of difference in receptor sensitivity in the children, but the actual data it is lacking, and the reason behind is that there is very less research in case of the children. So one of the important problem it is the ethical reason that you cannot involve children in the clinical trial and conducting the trials, and another thing is that the children they does not need much frequent treatment as compared to the adult or elderly patient, right? So that is the reason the documented evidences, although they are there, but the difference in the receptor sensitivity in the children it is lacking. So most of the time how drug it is going to produce pharmacological action it is unpredictable, and due to that reason when new drug it is launched into the market and if it is given to the pediatric patient, that patient must be kept under strict surveillance, right? So either you can do the active surveillance process or you can have the retrospective surveillance if you witness any adverse drug reaction. Next point it is in case of few drug it is observed that the child they produce very unusual effect. So unusual effects it is observed with few medicine in case of the child. Let's see what are those unusual effects. So unusual effect like the hyperkinesia with the phenobarbital. So phenobarbital basically it is a hypnotic drugs. It actually produces the sleep in the adult, but in case of the some of the child, instead of producing sleep, it increases the or it produces the more activity. So that is called as hyperkinesia. So it produces the hyperkinesia in case of the child, and it also produces sedation in case of the amphetamine. Now you can see the amphetamine it is basically a CNS stimulant drug. Okay, so actually amphetamine produces the hyperkinesia, but here phenobarbital is producing the hyperkinesia, and amphetamine it produces a sedation in case of hyperactive children. And the one of the important drug for the treatment of hyperactive syndrome in case of the children it is the amphetamine. Yes, so this is just reverse effect it is seen as compared to the adult. Again, how it's occur, why it is happening, there is no reason or there is no scientific evidences about the justification on what is happening at molecular level with drug is available. So most of these reasons are unexplained. So I have given you two example. Likewise, there are many drugs they produces the unusual effect in case of the children as compared to their pharmacological action in case of the adult patient. Okay, so this is the pharmacodynamic changes which is occur in case of the children. We will see few more example like it is observed that the effect of warfarin it is augmented. So if you give warfarin as an anticoagulant in case of the child, the normal dose it may produces the major hemorrhage that could be life threatening to the child. Okay, so you must be very cautious when you are giving warfarin as anticoagulant. Then in case of cyclosporine which is immunosuppressant and it is generally given in case of the organ transplant. So suppose in case of child you did some organ transplant, then you are giving the cyclosporine. So in case of cyclosporine, so when you did the in vitro study, that is test tube study, to the cultural monocytes which are taken from the child, it was observed that the cyclosporine effect it is more. So the greater effect in a cell which are isolated from the infant as compared to those cells which are isolated from the adult. Okay, so the effect as compared to the adult it is increased to the cyclosporine it is observed in case of the child. So these are different pharmacodynamic effects are seen in case of the children. So we have seen that As far as pharmacodynamic is concerned, the receptor sensitivity, data availability, it is very less. So most of the time pharmacological action, it is unpredictable. So when you are giving treatment to the child, they must be kept under strict surveillance. And as a parent or as a relative of that child, if you feel any unusual reaction, you must immediately report to the physician. Okay. So and then we have seen there are many drugs like amphetamine, instead of producing CNS stimulant effect, it produces the sedation. Likewise, phenobarbital, instead of producing the sedation, it produces the hyperkinesia, right? And then we have also seen the example of the warfarin, where warfarin, their pharmacological action, it is increased. Okay, so these are different pharmacokinetics and pharmacodynamic effects are seen in case of the children. So I have referred these books, the James M. Ritter, the Lion D. Lewis, the Timothy G. K. Mans and Albert Ferro, or the Clinical Pharmacology and Therapeutics 5th edition textbooks. I must thank the author of these textbooks for providing wonderful information on pediatric medication and the effect of especially the special populations, how pharmacotherapy or the effect of the drug, it is changed in case of pediatric patient. Okay, so I've done with my today's session. Thanks for watching my session. For more such learning, subscribe to my channel, and if you like my session, then do remember to give me a thumbs up.